Right, good afternoon, everyone, and welcome back. It's now 2:20, so we're going to kick off with our fourth session of the day. For those of you who may be just joining us, just a quick hello and introduction from me. I'm Jacob. I'm the new Chief Exec at National Voices. So delighted to be chairing this session, which, as per the earlier sessions this morning, we will have a presentation about the subject of multidisciplinary teams in this one. That will be followed by a Q&A followed by a panel session, and then a Q&A at the end. And if I can remind people, please put your questions in the chat as we go, and we'll be collecting them at the side to play back to our panelists and get the questions answered at the end. Any questions we don't get to, we will take away and consider how we can get answers to you for those post the conference. Just a couple of housekeeping things. If you could remember, please keep yourselves on mute, but your cameras on if possible, just so we can see who we're talking to. For the accessibility requirements, a reminder that we do have the speech to text service in operation and British Sign Language interpreters available. So if you want to know how to access those or you have any issues, please put a comment in the chat or email info@nationalvoices.org.uk. And just a final reminder, we will be recording this session and making the recordings available to people post the conference. So if you miss the thing, you can catch up later and you can share it with colleagues as well. So this session this afternoon looks at the changing model of general practice and how we can make the most of multidisciplinary teams to achieve what we're talking about here is joined up, person-centered and equitable care. We've said that at various points today that the model of general practice is changing, but what do we mean by that? Well, we know that we are moving away from a time when people always saw their GP to one where people now consult with a range of different types of healthcare professionals. And actually there are, over 15 different types of skilled roles in primary care now, everything from nurse practitioners to physios, pharmacists, mental health workers, the whole family of different roles that now provide care for people in primary care settings. Yet for many people, accessing care or going to the GP is still synonymous with seeing their GP. And actually that sometimes can be quite confusing about the way people give feedback, because they can talk about wanting to see the GP, but actually they're talking about accessing their multidisciplinary team. It gets all quite confusing. So that's what this conversation about today is, to unpick that a little bit and find out what people are really saying about their experiences of MDTs. To do that, National Voices carried out a recent series of focus groups to understand how frequent users of general practice and those experiencing health inequalities have experienced this shift away from a single GP to this range of professionals. And as per usual, we ran those workshops and those focus groups to establish what's working well and where things could be improved. And in a moment, I'm going to hand over to my colleague Sharon Brennan, who is the other half of our Head of Policy and External Affairs job share, and she's going to present the findings of the work for us. And then we'll be joined by our panel, which this afternoon includes Dr. Minal Bakai, who's the Director of Primary Care Transformation at NHS England, James Sunderland, who's a freelance writer and expert by experience, and William Hyam, who's Director of Community Mental Health Unit at Rethink Mental Illness. So I think we've got about 5 minutes for each of the panelists after Sharon's presentation, and then we'll move to the Q&A as before. But for now, I'll hand over to Sharon for your presentation, please.
Thank you, Jacob, and thank you also to Sean and Claire, who precedes me. Sean is actually an old colleague, so I hope he doesn't show me up in my presentation. I think Jacob really laid out the issues behind this session. So I should be looking at the report that we've created, which is called Feeling Part of the Team, joined up, person-centered, how we improve joined up, person-centered and equitable care for people who are using MDT within the general practice. We know that primary care is very much the front door for everyone, but it doesn't always work for everyone in the same way that it needs to. We've already heard from Jacob that the system is moving away from using GPs solely and moving more towards multidisciplinary teams. So for those We've obviously experienced similar things. My mother-in-law, for example, had a poor hip. She didn't see her GP, she saw a physio. And I think Sean, in his earlier conversation, touched on something quite important. This shift to MDTs is we're very much aware of it within VCSEs and within the system, but it's not so much aware within the local community and people that use those services. And there's still that perception that going to the GP means you're seeing a GP. So with this project, what we really wanted to look at was to see the change in awareness of people who use primary care, to see if they understood what an MDT was. And thank you for Rebecca Steinfeld saying MDT is multidisciplinary teams. To see if they understood what MDTs were, any unintentional consequences for users from moving from GPs to other skilled roles within primary care, how we increase trust with users, and how do we ensure that people are assured that they've got oversight of their own conditions, so that someone with long-term conditions, for example, may see multiple people, but we assure them that they're going to receive the same care and the same level of communication that they would have if they'd just seen one person. Before we move on to the next slide, I just want to lay out the scope of this project. So we did a rapid evidence review, which means we looked at existing information that was on the website and with other VCSE groups to see how people use multidisciplinary teams. And we very importantly looked at 3 insight focus groups. So for that, we talked to 15 people across a diverse range of needs and practices. So people with ethnic minority backgrounds, people who are identified as LGBTQ, those that are touched the criminal justice system, and people with mental and physical health needs as well. And on top of that, we talked to 14 different VCSE sectors, voluntary and community social enterprise groups. Just to place a bit of context, we've obviously heard from Claire Fuller earlier when she was talking to Sean. Her report, the Fuller report in May 2022, was very welcomed by the system and underpins a lot of this change that we're discussing today. I'm not going to go through all of it because it's quite detailed, but 3 issues to highlight was that she called for greater choice for people who are infrequent users of primary care. So those people who maybe just go to a GP once or twice a year, how they best want to get hold of a GP or rather a skilled practitioner within primary care. She said we need to be better at offering proactive care for people with long-term conditions and ensure it's personalised to their needs. We heard really well from previous speakers today, such as Gary, about the needs that he specifically has and how a GP and the multidisciplinary team needs to respond to those. And also there needs to be a greater focus on prevention, not just helping people when they're ill, helping them prevent them from getting ill. And this fits quite nicely into the primary care recovery plan, which my job share, Dr. Rebecca Steinfeld kindly talked through earlier. Very much you'll have seen in the media, this was talking about ending the 8 AM rush for appointments, but within that, there was a lot more detail that's really helpful for framing this conversation. So there's a need for receptionists to be better trained, so they become care navigators, and they can help people understand who they'll see and when. And also there was a need for a major communications programme, so that people understand that there are changes that happen to the GP system and how that might affect them. We also saw an injection of cash, £385 million, which will be used to improve link workers. And for those that don't know, that's for people who can help signpost people to care that maybe isn't necessarily medical centred, but could be around accessing peer groups, accessing park-run groups, accessing kind of support to help them alleviate things like loneliness. So I will now go to the next slide, please, Lucy. So just to give you an overall key theme and summary before we go into more of the detail, we saw 3 key perceptions about multidisciplinary teams. There was a low level of awareness of what they were. People are still very much, as I mentioned earlier, thinking they're going to see the GP, and they don't necessarily know what it means if they don't. They are unfortunately seen as a cost reduction measure, something the system is implementing rather than something that will benefit people. And they're also seen as a further barrier to healthcare, especially for those that are already experiencing barriers to healthcare, such as those within health inequality groups. Talking of barriers, there were some common ones that we found: a focus on repetition and having to repeat yourself to different audiences, a lack of continuity of care or involvement in decision making, the confusion of who to speak to and what to expect, and fears people need to invest more time and energy into navigating care. And that was particularly important because we know people with long-term conditions already feel they spend a lot of their kind of personal admin trying to access appointments and chase up results. But there was evidence of what works well. Very much MDTs at work are co-produced for patients. They are promoted and understood within the internal organisation, but that means that they know who they're referring to, what different roles are within their team, and that they trust and support those people within their team. and that they value the importance of non-clinical roles. So I just mentioned about link workers, but this can also include social care workers. We have seen, though, that they do need to focus on proactive care planning, which means removing, focusing again on prevention and how we can keep people well with their conditions. So next slide, please. So we did a lot of work with our focus groups, and I think this is where we've really kind of seen the in-depth understanding of what MDTs are. Talked already before about how there was a low awareness of MDTs, and there's 9 other insights we also gathered. The first is there's some rich responses to multidisciplinary teams. We heard one person say that their surgery signposts very clearly and they've seen big changes. Another person saying that no one understands my health because they don't believe when they're moving from one person to another for their care that people are listening. As I said before, they are seen as a wider rationing of care. But when you actually drill down into the care people receive, they are actually pleased with the care they receive from people who are not a named GP. So there is a kind of a conflict going on within that finding. Those that are already experiencing exclusion face more barriers. So people said it's more complex if they use interpreters. And one person who identifies as trans said they already find it difficult to trust one person. So it's even more difficult to trust a lot of people. And they quite often, they talked about having to consistently ask people not to use their dead name. Repeated need for repetition erodes confidence in care. One person called it a death by assessment. And I think Gary Burlett, he spoke earlier, talked of his own memory needs and the fact he's got mild learning disabilities, and sometimes repeating things is much more onerous on some patients than others, and that has to be taken account for. People do not feel part of the team. We know that MDTs have discussions about people's care and they don't actually tell patients what was discussed, and people say they need a summary of that. And I think that's also really important, ensuring that people feel they can advocate and self-manage their own care. Continuity of care is an issue. We already heard Claire Fuller talking about this, and I will go into further detail in the next slide, but continuity of care with the MDTs, when people are used to speaking to one person and now might speak to 5, is an issue. One person that we spoke to said that maybe a central person to help families would help. We also said that constantly repeating yourself to different people makes you feel like no one is listening, and that the GP knows them on a personal basis, so why would they want to move from that? Again, there's a confusion about who to speak to and what to expect. So we've heard that people are pleased to speak to someone quicker, but they don't know what their role is or why they're speaking to that person. And with what to expect, people can't build and kind of prepare themselves for meetings because they don't know who they're speaking to. So one person said, for example, they'd been triaged by a nurse and they didn't understand what triage was and was told they were to speak to a paramedic. And although they were pleased with the outcome of that conversation, they didn't know why they were speaking to a paramedic and wasn't able to prepare themselves for that meeting. And finally, as we discussed before, there's fear that it adds extra bureaucracy. We've heard from people saying that it's just another layer of bureaucracy, that people feel they're kind of bashing head against brick walls, just trying to get blood tests. And I think this issue around bureaucracy will be a key one in terms of ensuring that we bring people on board and make them feel like their care matters. So can I have the next slide, please? With all this focus group work, we did pull together what good looks like. They need to be co-designed to include people who experience inequalities. They need to make people feel welcomed, understood and listened to, and also people have to remember what they've heard the first time round. They need to be designed to build trust and create continuity of care, which is one of the action points I'll come on to on the next slide. And really important, they need to value the time and energy of patients when they're trying to navigate the system. Proactive communication is really important, not just around individual cases of who they might see, but actually about the changes themselves across the nation to GPs. And they must include and involve people in decision-making around their care. We hear this all the time, and it's been a well-worn concept that people must be involved in their care, but it's still something we struggle to ensure that people are receiving. And finally, they need to be transparent, and we need to follow through with promises, especially at the moment we're hearing where people are maybe chasing up a blood test that they promise they'll be told the result to, that kind of thing, where you're told that you'll be given a call and then you're not, does erode confidence and makes people feel like the system isn't really working. So next slide, please. So we have developed a set of proposed actions. Obviously, doing this work is important, but actually trying to make change is just is more valuable than that. So there's a series of 5. We very much want NHS England to ask primary care networks and integrated care systems to measure the success of a multidisciplinary team against what matters most to people. We know the National GP Improvement Programme is looking to improve how GPs measure things, but we know that this needs to be better, have better investment and leadership and communications, so people actually have the headspace to make that shift from system outcomes to person-centered outcomes. So very much that's about trying to measure what matters to people and understanding what matters to people first. Action number 2, we talked about this before, GPs must deliver better and more consistent messaging and explain the benefits of MDTs. The primary care recovery plan, which I've touched on before and which my colleague Dr. Rebecca Steinfeld discussed in more detail, does actually lay out a national communications plan. And we are asking NHS England to ensure that explanation of multidisciplinary teams is part of that. It may also need a renaming. MDTs is very much a system focused name, and it doesn't necessarily say much to patients. So can we do better in that? Our 4th action is that we're asking integrated care systems to work with general practice to co-design services. We do know this happens already. We've seen practice patient participant groups, but the challenge back to the system is are these groups really looking at a diverse group of people with lived experience and learned experiences, especially considering that we know that people who use MDTs, those who are already facing inequalities feel like they're facing greater inequalities, and they're exacerbated by MDTs. So they really have to be co-designed with a diverse range of users. And finally, GP teams must actively involve patients in discussions and decisions about their care. I've missed number 3, so I'll come back to 3 in a minute. GPs must actually involve patients in discussions and decisions about their care. I was very impressed by the words from Gary earlier, and also from our previous person with lived experience, whose name escapes me, when they were talking about how they are a person, not a condition, and the need for MDTs to really come together, review conditions as a whole holistically. That's the kind of thought and consideration that can be unearthed by involving patients in their care. And really without that, people won't be able to have trust and belief in the system. And finally, let me go back to number 3. We've already heard from Claire Fuller, and I actually admired her candidacy in the earlier session about the need to improve continuity of care in MDTs. It is difficult because, as people say, if they're used to seeing one GP, why would that give them less continuity of care than if they saw multiple people? And we're asking NHS to explore that on a national basis. So one of the examples we've had already from the primary care recovery plan is that receptionists are going to be trained up to be better care navigators. So how can that role be expanded and explored to improve continuity? And we also know that NHS England is going to be investing more money in digital, basically into the background of GPs to improve their digital technology. How can we use that to ensure that people are reading the notes fully and updating on whoever they see as a patient, and how that helps them to improve their care? So I think that in our actions, there's some straightforward ones, such as comms messaging and involving patients, which need to be reiterated and focused on. And there's some also challenges to the system about doing things differently. Just go on to my next slide before I hand back. It just leaves me here to say thank you to our funders and supporters. So we couldn't have done this work without the contributions from BCSC Health and Wellbeing Alliance, which is funded by the DHSC, UK Health Security Agency and NHS England. And also thank you to the wealth of BCSC organisations that we spoke to, especially those people with lived experience that helped us develop and understand the needs around MDTs. And with that, I shall hand back to Jacob.
Thank you, Sharon. And in the interest of time, we'll move straight on to our panel. And first up is Dr. Minal. Minal.
Thanks, Jacob, and thanks, Sharon, for a really great presentation. And I just want to say I'm really grateful to the National Voices team, particularly Sarah, who my team has worked very closely with and collaborated on this. And I just hope that we can really shine the spotlight on the power of partnership and co-production between our teams and that diversity of thinking, because I think that really comes through in this report, particularly as we work through very complex issues together. So thank you for everyone that contributed. I think, as we've heard earlier, the demands on general practice have never been greater. We've seen record numbers of appointments being delivered, 500,000 more every week compared to pre-pandemic levels. And we've also heard that this is not really just a COVID effect. We are seeing our population grow, and most of that growth is in our over 70s. And while it's absolutely fantastic that we are living longer, and that's something to be celebrated, the age of onset of major illness has not changed. So we are living longer, but with multi-morbidity. And I think, as Claire highlighted, we are facing significant challenges with regards to recruitment and retention, and the biggest reason cited by staff leaving are burnout, stress and workload. I think it's something to be celebrated that actually, despite these challenges, patient satisfaction with the care they've received from their general practice teams remains high. However, I think it's absolutely important to acknowledge that people's experience of contacting their practices has seen a significant drop. And this is not just an isolated problem, it's across most of general practice. And so the emotions that I'm sure all of us here will recognise, and I'm a GP, so I certainly recognise them in my own practice, is that our patients and communities are feeling confused because things have changed so rapidly during the pandemic, and we've not been able to take people with us in the way that we would have liked to. And so people are not sure how services work anymore. There is frustration with the 8 a.m. rush and being told to call back the next day. There is worry, will I get an appointment when I need one? And there's a feeling that the service is unfair. You know, it's fastest finger first come, first served allocation of appointments. It's not necessarily the traditional model, not based on need. And similarly, from a general practice perspective, the current model means that staff feel like they're carrying increasing clinical risk as demand and complexity increases. It can be increasingly difficult to plan work as effectively as we'd like if we're not able to see all of our demand. And if we're not able to understand people's needs fully at the point of contact, then it becomes very difficult to prioritise care safely and easily and equitably based on need. And so I think for me, this calls out two really key things. We absolutely need to maintain our critical focus and investment on recruitment and retention. We need both more clinical and non-clinical staff. But we also need to make the best use of the workforce. And we need to have a modern model that supports general practice to be fairer, safer, and more sustainable. And so the delivery plan for recovering access to general practice discusses a move to this modern general practice access model. And essentially that involves some really key steps. The first is that there is parity across different access channels, so across online, telephone and in-person channels. There is no one size fits all. We know that people use them flexibly based on their need, their confidence, support and skills. But regardless of how you contact, people are treated in the same way. That for practices, they're able to see and understand all that demand that's being expressed and therefore be able to plan their processes, their rotas, the way they work better, differently. It's about being able to capture information up front to support that safer, more equitable allocation of capacity, but also provide that greater personalisation of care. So understanding what people's communication needs are, for example. And that includes designing for and therefore improving the continuity of care where needed. So being able to identify those with continuity needs or who would like continuity so that we can try and improve that. And then it's about making full use of the multi-professional team and improving our working environments, as well as improving patient experience of contact through enhancing the quality of our access journeys. And that will be supported by investment in better digital tools and telephony. And from my perspective, I think the multi-professional team have the potential to make a really significant contribution to this and the quality of patient care in general practice. And they represent a significant investment in the future sustainability of general practice. So the additional roles scheme, which I think was mentioned earlier, that was established in 2019, provides funding for practices for additional staff to be employed as part of multidisciplinary teams within primary care networks. And PCNs, primary care networks, have made excellent progress in recruiting to these roles under the scheme. As of the 31st of March 2023, there were just over 29,000 additional primary care staff that have been recruited since 2019 across 17 different roles, with more and more flexibility being introduced. But it's not just enough to have the roles. These roles need to be carefully embedded and integrated into general practice primary care teams if they are to reach the potential for patients and to meet the needs of staff working in the roles. And we know the evidence and Claire cited some of it, suggests that team-based care offers advantages in delivering the core attributes of general practice that include improving access, more efficient coordination, improved continuity, so that when patients access the expertise of a variety of team members, they're more likely to get the care they need, i.e. getting it right first time. But I think it's worth calling out that traditionally, the way the NHS has managed complex change has been through an over-reliance on contracts and micro-incentives. So why will it be different this time? Well, there is, through the recovery plan and through the vision of the fuller stock take, an investment in culture, in leadership, in improvement, in capability building, in active learning, in co-production, in peer-to-peer learning. Because what has been clear is that we need support for practices and PCNs and their communities to help them build a clearer shared vision for a multidisciplinary model of care that's co-designed and that helps translate the policy into what it means for them locally, for their local population. We heard a lot about localism. To be providing a package of support that helps practices and PCNs working with their communities understand the need, know which roles to recruit, and then integrate them into ways of working. So understanding the skills and their scope, avoiding duplication so that people can be navigated the right person first time more easily, identifying and improving continuity of care where needed, and providing more flexible ways of accessing and delivering care, because there is no one size fits all. I think communications is absolutely critical. From the work that we've done, particularly the user research that we've done, we also have validated, I suppose, the findings that Sharon described, that patients are not always sure of what the different roles mean. What is MSK? What is first contact physio? What is a social prescriber? What those roles can do, and more importantly, will they be able to solve my problem? And if I get offered one of those, will I lose my place in the queue for a doctor if I have to go round the loop again? So I think it's about being able to provide clear communications that can hone in and on some of those messages. I think stability of policy is absolutely key, and NHS England has confirmed a continuation of the R scheme beyond the end of the 5-year contract, and then ICBs leading and supporting some of those local conditions for change, particularly time and headspace for training, supervision, estates, etc. I just want to call out one of the key things that is in the plan is that there is a nationally funded support programme, the National General Practice Improvement Programme, and this is helping support practices and PCNs to make these changes towards a modern general practice approach more easily, and helping patients and practices realise the benefits more quickly by codifying the great work that practices and PCNs have already been doing with their community. So it is very much bottom up, but it's about making each of those steps more rigorous so people can get the most benefit out of them. It's about getting the right technology, the high quality digital tools that are usable and accessible to help enhance those benefits, and then knitting it all together for biggest impact. It's about investing in training and building capability and skills in-house, internally within the NHS, to drive and sustain change, but at every organisational level, recognising the real impact that systems are going to need to have in terms of supporting primary care, and then creating active learning systems. The way that we deliver transformation is through social peer networks, through working collaboratively through communities. And so it's about setting up those communities locally to be able to share challenges and learning. And then, of course, that is supported by alignment of incentives and funding to help try and create the headspace and capacity to do this. And my final point that I just want to make is really about the evidence. Practices have done this, many practices have done this. And when you get the elements right, the evidence tells us that overall patient experience improves by 6 percentage points from the national average, that continuity of care improves, people's experience of contact improves, people have more flexibility in how they access, and you see that flexibility in the data, that practices provide a more responsive service. You can see them prioritising care based on need. And actually, it busts the myth that everybody wants a face-to-face, because actually only 12% of people on average in those practices request a face-to-face because they feel confident in their practice. And they feel confident in being able to access the care they need when they need it. I'm just going to stop there.
Thank you, Minal, for that excellent presentation. Lots to unpack in there, and we'll get to that in the Q&A. I'm going to jump to James now. James is a freelance writer and expert by experience. James, do you want to unmute yourself and come in?
Yeah, sure. Thank you so much for having me. So I'm going to talk about my personal experience in accessing MDT care or multidisciplinary teams care as a someone with chronic illnesses, neurodivergent, and I'm also transgender. So I've experienced a lot of different streamlines into trying to access care through both primary and secondary and tertiary care. And I'll first start by going, obviously this is a personal experience, everyone's experiences are different, you know. So through my personal GPs that I've actually been with since I've been about 8 years old, excluding time when I went away for university, we've quite recently, in the past few years, just before the pandemic, started transitioning to becoming a multidisciplinary team-based practice. So everything's done through e-consult initially for most patients. This was, as someone who I had immediate issues with this, because I am someone who I very much worry about talking to a new doctor, because not only am I worried I'm going to have to repeat myself like people have mentioned before, but there was worries about how will they react to me being transgender, because they have the power to go, actually, I'm going to take you off hormones that you've been on for so many times, even though ethically they shouldn't do that. You know, there's a lot of anxiety because there's a lot of control, especially for someone who relies a lot on the care that primary care provides. I was very lucky in the sense that because I've been with the local GPs for so long, they know me very personally. And so I was able to navigate the e-consult, and essentially when I started to sit, once I understood that I could go through e-consult and request to see someone specifically, it was all cleared up. I know there's a lot of people who have chronic health issues who have had issues accessing things like e-consult. Oh, sorry, I realise I've mentioned this, but not necessarily defined if you don't know. So e-consult is where you go on, you access it online, it's open during practice period times, and you say essentially why you need to see a doctor or nurse or another primary care practitioner. You explain what your symptoms are, you provide pictures if you need to, and you say if you want to specifically see a certain doctor or nurse or practitioner or not, and they will triage your request within 24 hours. For me, my experience has been it's actually triaged within an hour or 2 hours, because they've got very quick at being able to look at this and navigate it. And you get either assigned an appointment, depending on how urgent they feel it, over the phone or in person, and it can be up to 2 weeks away, but quite often it's within a week. They'll give you a call, or it's quicker if you have more urgent issues. Something that I have found, though, as someone who's not only accessing care, is that although it can be really good to have a team that's all communicative, so I see the nurses at least twice a month, and I see a GP about once every 2 months for primary care, due to unfortunately secondary care being lacking in certain things. There is definitely a benefit in them coming in and knowing instantly what, you know, up to date as much as my other people I see. So I can go into my nurse, and because I see her so frequently, she can tell almost immediately, because it's one person who I see within that team, that something's not right or something's right, as it were. But that is mainly reliant on the fact that I see within my multidisciplinary MDT, I see specific people. I don't see other members of the GPs. I'm not doubting that they would be able to come along and go, yes, I can provide up-to-date health on this, but there is a huge amount of anxiety for myself, and I know for a lot of other patients, that even if they're kept up to date, you have to repeat yourself, and that energy is not necessarily something that, like it's been mentioned before, available. Something I have noticed with people who I know who either work as GPs or in receptionists and local practices is that I know the practice that I attend is the only traditionally GP-led practice in the area. So there's quite a number of GP practices that are owned by companies or conglomerates or co-owned, and that has a huge impact on the positive care that I receive. So there is a basic, I know from talking to people who work in other practices that, for example, a friend who's a receptionist, she works in a practice where they don't have any permanent GPs, where they're all locums. And so they've had that for over 2 years, and the locums that only have 3 month, 6 month contracts. So they have patients who are continuously not receiving, even if there's no continuous care within their health, even if it's something that they do have a multidisciplinary team where the nurses are where the nurses are informed, where physiotherapists are informed, where mental health practitioners are informed within the team. There's no passover because there's no one there long enough to actually see through treatment. And it's something that's really, I know that the NHS has been talking to my own GP. They say it's really a struggle because the NHS is trying to force out traditional GP ownership or GP-led practices. And I know there can be good ways of practicing, of GP practices. They can be owned well, as it were, and it can be done well. But in my experience and experience of a lot of patients and friends who have got chronic illnesses, disabilities, there's no positive impact of when ownership is taken away from those who actually know the patients. And not only that, through receptionists who they deal with potentially a lot of issues where companies refuse to fire or talk to locum doctors who don't do their work, or nurses who don't do, there's been quite a few times where locum doctors then go to receptionists, well, you should tell them to do this. And it's like, well, a receptionist, that's not their job to provide healthcare advice. They've not got no qualifications to provide medical advice. One thing, sorry, I know I'm talking a bit. One thing that I do think, last thing I'll just say is that I think what's really positive and what can be brought out for more people is transparency on communication. So I personally have access to an online account, which I know a lot of GPs do now, and it provides you every time they ever log something against you, or mention, so move your files, they communicate every time they talk about something, it's mentioned, so you can see with transparency and trust on what's going through. So you can see, I've talked to the doctor about X, they said they would phone up about X, Y, and I can see that they've actually gone through and done that, and it's logged that they've done this. So I have trust in my practice. And I think that's something that not only working on making sure that communication is clear to other patients, especially ones with other needs that may not be able to use, may need extra explanation, but I think just providing autonomy to patients when it's possible is something that's really important for both trust and for success in patient care. And I'll stop talking now because otherwise I'll keep talking for years.
Thank you, James. It was excellent. Some great stuff in there about the importance of explaining how things like e-consult work and how the difference that can make, and also that I think that last point about how you can see when actions have been agreed to and that they're being followed up by your doctor, how that can really build confidence that your care is being looked after. So thank you, some brilliant reflections. William, you're our final speaker. Do you want to come in and with your 5 minutes, and then we'll take a couple of questions from Pavi?
Sure, thank you. So my name's Will Hyam. I work at Rethink Mental Illness, which is the charity for people severely affected by mental illness. And I'm just going to talk briefly about some work we've been doing around stretching the multidisciplinary team model a bit in Coventry and Warwickshire. Stretching so it can really meet the needs of people severely affected by mental illness, and stretching to include the wider social care and voluntary sector community. And really, for the 500,000 people we represent whose life has been severely affected by mental illness, primary care is quite a difficult terrain. There's a big gap between the help and support you might be able to get at primary care and what you might get at secondary care, and moving back and forth. We've been really involved in the community mental health transformation that tries to close that gap a bit and bring in elements of social care and wider support in the community. So a couple of years ago, we piloted MDTs in one Coventry and Warwickshire PCN. It's now in 11 more, and it's supported so far about 140 people in the pilot, which we continue to expand. But the idea was to bring together the voluntary sector, usually the social prescriber from the practice, and social care and other functions. And typically, the kind of anonymized patient record cases that people were looking at were people who were really struggling, going round and round to get the help that they needed in primary care. Obviously, we co-produced the model, and one of the concerns that's always there at the beginning is anything other than time with the GP sort of second best? And that's a concern both for patients and for GPs themselves. I think what we've seen by bringing in organisations in the community that specialise, say, in domestic violence, specialise in helping people sort out their rent or their benefits, by befriending schemes for people who are isolated, particular knowledge of conditions that are more specific, and crucially, organisations based in underserved communities. We were able to find that the expertise there was so much beyond what could be offered just by the PCN alone in a particular area of someone's need. And also you have the ability to make a whole package, because rarely do people come with one need, that we've seen really sort of high scoring and acceptance from both patients and clinicians. And I'm really, I've sat in on quite a few sessions, and the experience of being, say, the social prescriber, trying your best with the tools that you have, which very few often, to help someone who keeps coming round and round and is in obvious need. You can see the stress that has on people, and the stress lifting if you're able to have 14 people sitting around with you with varied expertise of local assets and resources. You can really see just even sharing the knowledge, yet alone having new destinations, opens up new possibilities. But beyond that, I think we do need to look at how we get within the mental health transformation, within the ICB world, within the new health system that's being set up, how we can make sure we get the right resources to the community to help out. On the whole, the smaller charities are struggling enormously. You know, just in Coventry and Warwickshire, I'm thinking of an amazing charity that works with young parents who are in trouble, that itself is now in trouble. And what happens back to the system if all of those resources in the community drop out? So I do think that it's important to take a long-term view about how you provide the micro-funding to enable smaller charities to be involved, particularly those that work with underserved communities, where attending a lot of meetings is not easy for an organisation of 1 or 2 people. So we have managed to get funding into the model for attending the MDTs from this point. So that's my plea, not for big charities, Nate, like mine, but for little charities in particular, smaller charities. So I think it's really exciting. It goes alongside, people have been mentioning R's roles in the chat, a SMI navigator role we've developed in North East Links and spread out there. And I think whatever it is, there just has to be a way that you find people who can access all the local assets and resources and intelligence, and can actually spend some time with and thinking about a patient, to make sure that in addition to the GP time they need, they're able to get some of the wider care and support that they need and they say they need.
Thank you for that, Owen. I'm going to move now straight to the questions, if we can. And I'm going to actually think, Pabby, do you want to come in with that first question? I think we might pass it to Will, reflecting on his last comment. So, Pabby, do you want to come in?
Yes. So our first question is, can anyone tell us in what sense multidisciplinary teams actually behave as a team? It seems that it's just a label used to justify the allocation and fragmentation of tasks among a number of people. Do members of multidisciplinary teams in practice consult with each other and work together as a team for the benefit of patients, in particular those with multiple conditions?
Thank you, Pabby. So, Will, I just thought that was interesting what you were saying about, being able to feeling less lonely if you've got a range of professionals you can work together and call off all the different resources. But how common is that as how you see MDTs working, or is that a one-off example?
Well, I can't speak too widely. I can really just say what it looks like when it works. That for me, the point of assembling a team beyond one organisation is to bring together complementary expertise and resource. And as I was saying, that people living with severe mental illness are a whole person with a whole set of needs, and typically they will face exclusions and consequences from being unwell that affect their housing, their social life, their financial status. And getting that team together doesn't just enable people to support each other, but it enables that whole person, if you get it right, to be supported. I've seen it work. I know it. All of these things need development. They need investment. They need some work around the cultural side, like shared induction materials. But I know it can work, and it's a powerful thing. There's a powerful prize if you do make it work.
Thanks, Will. So, Minal, you've got your hand up. Do you want to come in on that question?
Sorry, my actual hand up. Well, I guess I wanted to just share my experience really as a GP. So I work in Brent, in Harlesden, a really deprived part of the country, diverse population. Often my population haven't had the same opportunities in terms of education and training. And just an example, I think, of, where I think multidisciplinary working has a huge value. So I think two things. We saw lots of it during COVID. So a lot of my patients were shielding and isolating, a high risk. We shared data between local authority, BCSC sector, primary care, and we came up with coordinated approaches to proactively support our patients, and both in terms of physical and mental health. And I think that's really important, as well as, vaccinations and that sort of thing. I think just on another point, prevention is absolutely key, but particularly in my area, there's a lot of mistrust. And so, screening, for example, cervical smears, we didn't have a really high uptake. But what we have done is we have brought in people from the community. We've got people that speak native languages, that understand the communities, that look like the communities that we're serving. And they, as health coaches, as healthcare assistants, and they have had an absolutely amazing impact on being able to increase the uptake of screening and prevention, which obviously in the long run has huge positives in terms of health outcomes. So I think it is happening. It's probably not happening at scale everywhere to the level that we want it to, but I think there's so much we can learn from all the good practice that is happening, and then try and codify that to make it easier for others to do and create the right conditions.
Thanks, Minal. I'm just going to cheekily ask you another question that's popped up in the chat, talking about the team element of MDTs. What do you think of the concept of patients being part of that team as well as a GP?
Brilliant. And actually, where we've done the best improvement work with practices, patients have been part of the practice team driving the improvements, signing off navigation protocols. They have been intimately involved, and that is where the most sustainable, most effective change happens. So advocate for that fully.
Thank you, Minal. Pabby, do you want to come in with question 3?
Yes, we've had quite a lot of conversations around co-design and co-production, but how do we ensure that that is done meaningfully and it's not just a one-off or tick box exercise? And sort of building on from that, what's the role of patient participation groups in helping to manage change through collaboration between patients and local primary care professionals?
So I know, Will, you've got your hand up, but I just want to come to James first. James, on that co-production point, how do you think it can be done meaningfully and not as just a one-off? And then Will will come back to you.
I think it's difficult to try and sustain that energy, because not only, I think, I'm going to be honest, I'm not entirely sure how it can be done without it sitting there as just a tick box, without you going every few months, going maybe once a year or once every 6 months, sending out a survey and going, tick box. I mean, I have my own thoughts on patient participation groups, because I believe that there is an issue that it doesn't necessarily represent people with long-term conditions accurately, as a lot of people with long-term conditions do not have necessarily the energy or accessibility to these participation groups, which I know that they can be really useful, but I do also worry that there are people's voices that aren't asked, people aren't given the opportunity, or they are unable to give voices onto how to make things more accessible long term. I think potentially it looked like Will might have had some more suggestions on how to do integrating, because like I said, I'm not entirely sure on how to make it a sustainable thing without it being a tick box.
I think the point is, Jen, it's not an easy thing to fix, but we'll bring you in as the last comment. Sharon, I know you've got a hand up, but I think we're out of time and I've chaired this horribly. This session is only 5 minutes over already. So we'll let you have the last word.
Lightning points, because passionate about this in mental health, but experts by experience, it's important to recruit from the whole community, according to the full diversity of the community, to sustain and support people as a team, to pay them for their time, to make sure that there's someone who's nominated to work with and support them in getting their voice out, to give them positions of power, along with experts by training in the co-design of services. And it's a long, hard business, but if you do all of those things, it's probably heading in the right direction.
Brilliant. Thank you, Will. Fine words to finish on for the session. So I'll just wrap and say thank you to all of our panelists and our speaker, Sharon, for that session. Please stay on the Zoom link, but you can turn your cameras off. We're going to take a break now till 3:30, and we'll come back for our final session of the day and see you all shortly. Thank you very much.